Well, there are a lot of challenges to physicians being able to take the time to get out of their busy day to really take on a leadership role for improving care in their practice. And that's very understandable. The current payment system incents visits and tests, so it's understandable that physicians are incented to be in their practice seeing patients every day. So we try a wide variety of efforts at Maine Quality Counts to do that, and that starts first and foremost with keeping improving patient care at the center of our conversation. So we know that our physician colleagues didn't go to medical school to deliver bad care or to not meet quality targets. Everybody went to medical school to do the best they could for patients, and I would say it's really the very broken system around us that gets in the way of that. So by starting the conversation about what's right for patients, I think helps allow the conversation to happen and really gets us in the door. We also try to set up a variety of ways for physicians to learn from each other and to learn from other experts. In this very busy world of practice, there tends to be a real segregation these days of physicians in their ambulatory practices and others in the hospital, and not a lot of time for networking or learning from each other. So we sponsor different kinds of educational opportunities for them to really get together with each other, whether it's conferences, day-long learning sessions. We also host a whole variety of webinars and try to take advantage of new developments in distance-based learning to really help physicians share their experience and best practices with each other, which is enormously powerful. And again, they just don't normally have that experience on a day-to-day basis when their head's down in their practice. I think certainly helping bring to them what's new on the horizon can also be helpful in engaging them, again, with such busy practice and so many things going on in the changing healthcare arena these days. It's very hard to keep track of it all. And in our organization, I think we try to see ourselves as a sense maker, as an organization that can sort of both scan the horizon, see what's out there, what's coming, what's important, and try to filter and make that information manageable and understandable for physician audiences. There is a lot of this is a data-driven world these days, but in medical practice, that hasn't necessarily been a part of how healthcare is delivered. Physicians see patients every day, data is collected, but there's never been, with the old paper medical record, medical records, where now physicians, as part of their daily routine, are collecting and capturing information that is very important to quality. So in the old days when we might say to a physician, how are you doing with diabetes care? He might say, oh, pretty good. I saw Mary Jones last week and she's doing pretty well. But if you said, well, how many patients with diabetes do you have and how are you doing in meeting evidence-based quality targets? They would have no idea. They would literally need to go patients with diabetes in their practice, pull charts, look through charts, collect, just unmanageable, and it didn't happen, and there was no incentive for it to happen. Nowadays, with the use of electronic medical records and other structures like patient registries, which are really ways to collect information on patients with chronic illness for the purpose of improvement, we're able to encourage, and physicians have been able to really collect that data as part of practice, and then by doing reporting from that electronic registry or their electronic medical record, be able to see quickly, well, here are my 100 patients with diabetes, and here's how we're doing with controlling their blood sugar or their blood pressure or their LDL against an evidence-based target, and I know that I have room for improvement here, and we're going to try these changes in the practice to try to meet those targets in a better way. So I think that's been hugely motivating for physicians in a way that just wasn't available before. There is a lot of attention these days to creating financial incentives for physicians, and I would turn that around to say I don't think it's so much about financial incentives as much as trying to change the broken payment system. So again, this notion of changing how payment happens from just visit or test-based to paying for value or paying for quality. So in some of our efforts like the Maine Patient-Centered Medical Home Pilot, there's a lot of engagement of physicians around change, and at the same time we're working with the payers to change how they're being paid. So at least they're not hopefully being penalized for taking time out and working with their staff team to change practice.